Hello, Lowell. My name is Bill Garr. I'm the CEO of Lowell House, and we're an addiction and recovery agency in Lowell. We've been here for 45 years, and this is the fifth installment of our wonderful series. We've had a lot of fun doing this series and provided a lot of information, we hope, to you on addiction and recovery, and it's called Recovery Matters. And we have a very special guest with us today, and usually we have three guests. Today, I think we've limited to one because we want to hear a lot of what Dr. Brian O'Connor has to say. He is a very interesting guy. He is the executive director, CEO, president of Middlesex
Middlesex Recovery.
Middlesex Recovery. Has been in Burlington, now has an office in Chelmsford. So he's been a partner in a number of different areas. He is a real expert in the field. Originally an OB/GYN.
OB/GYN, yes.
Okay, and became. Why don't you tell us your story, Brian, instead of me trying to tell it?
Again, thank you for having me. My name is Brian O'Connor. I am both board certified in addiction medicine and OB/GYN. I started my career as an OB/GYN initially in the Army to pay for medical school, and started my practice in Melrose in 1991. Continued to practice there for the last 25 years. I delivered about 5,000 babies at Melrose Wakefield Hospital. Had a thriving career in OB/GYN going, but about 12 years ago I learned that my son was a heroin addict. And since that time I've been dealing as a parent with his addiction, as well as learning more about it, eventually becoming board certified in addiction medicine, and am transitioning my career away from OB/GYN to addiction medicine.
In fact, did I understand you the other day? This is your last week of seeing patients in OB/GYN?
Correct. A week from next Tuesday is my last day after 32 years of doing it.
Right.
So a little bittersweet, but I'm excited about the future and treating patients with addiction.
And it's great to have you because you've been a great addition to the area. Dr. O'Connor has a complete practice, but also does some in medication-assisted treatment. We might want to talk a little bit about that.
Okay.
And you've been open now in Chelmsford a week?
A month.
A month?
Yeah.
Wow.
Yeah.
All right, so let's get right to the topic. And the topic today is, how do you know if you're addicted? That's a question we frequently get from people. Yeah. We have people come to Lowell House and ask, am I an addict? Do I need some treatment? Do I need help? And I think that's a hard one for people to discern. It's also hard for parents to know when their children need help, when their children are in trouble. There's an occasional experimentation. So I ask you the question, how do we know if we're an addict?
Well, first of all, the nomenclature, or the words that are used in the substance use disorder, has now changed. And there is a guide that's used called the DSM, which is the Diagnostic Statistical Manual. And that is put out by the psychiatric community, and that's used for the basis for all diagnosis in psychiatry.
It's our Bible.
Correct. It's called the DSM-5. It's the fifth version of it. It's been out, I think, in the last 2 years. And they're constantly updating it with new definitions, new criteria, because, like anything, this is an evolving crisis, and defining what a disease state is the first way to begin to categorize it and eventually treat it.
That's right.
If you don't have a common definition for what a medical problem is, then none of the research really makes any sense because you're trying to compare apples and oranges. So again, about 2 years ago, they came out with some new criteria for the clinical diagnosis. So there's kind of two ways of looking at this. There's the parent looking at the child and saying, does my child have an addiction problem? And then there's the medical community looking at the patient to determine whether they do have it, and the severity of it, because the severity will ultimately determine what level of treatment they need, both whether it's medication or whether it's therapy, the site of the treatment, whether the site of the treatment is going to be inpatient, outpatient, residential, Florida, the bastion of where the cure is, which it isn't. But all of these criteria are based on having a common language. So what I thought I'd do to start off with is just going over what is the definition of it. Then we can go into how you look at it, but I think it's important for everyone to know in the beginning how the medical community is defining it, because you may end up going to the emergency room saying, you know, I got to help me, my son's an addict, and they may say, well, you know, we really don't think he is. And so I think that knowing that would be the first
And I
step.
think that's the confusing part for a lot of people. So we use my friend Joan as a reference point. And I'll tell you, we talked a little bit about Joan earlier, but Joan is very typical of a lot of friends we all have. She polishes off a bottle of wine at night. She shows up to parties and she's drunk. During the day, during work, during recreational things, she's fine. She doesn't drink that we know of. But yet we have friends that are saying, Joan, you're an addict. You've got to get some help. She says, I don't need help. I like to drink. I like my wine. So let's use those criteria and see if Joan's an addict.
That is perfect, okay? Because we all have Jones in our lives.
We all do. We love them.
Yeah.
And we hopefully drive them home at night. But in the end, they scare us a bit.
So what I thought I'd start is just by going over what the overall definition of a substance use disorder is.
Okay.
Okay, because it has changed.
And that includes alcoholism and drugs.
Correct. So there is a set of criteria that they look at. And there are 11 criteria that are very broad criteria. There's nothing absolutely specific to any individual person. It's really specific to lifestyle. So everyone shares these issues, whether it has things to do with work or interpersonal relationships or dangerous activity. All of those things are the criteria that's used. There used to be the dependence and addiction, or abuse and addiction, as the two criteria that they used to use. Are you abusing the medication? Are you addicted to the medication?
So what do they mean by abuse?
Okay. The word.
I have OxyContin in my house, and I have 30 pills, and the doctor says take one every day. Am I abusing that?
Well, it depends if you're following it. The word abuse means abnormal use. That's where it's kind of a contraction. So to be abnormally using a substance can be that you're using something which is not prescribed to you, that is not taking according, even if it is prescribed to you, if you're not taking it according to the label. There are certain, let's say in alcohol, okay, there are certain criteria based on your gender, okay? If you have taken more than 5 drinks in one day as a male and 4 as a female, then you are considered to have abused alcohol sometime in your life. So it's a very broad diagnosis. I mean, if you go to Fenway Park and it's a long game, there are many people that'll have 4 or 5 beers. Now, do they consider themselves abusing alcohol? Well, if it's done over 6 hours, probably not. If it's done over an hour and a half, probably yes. So you really can't use those specific criteria. According to population studies, a third of the population don't drink at all. A third of the population drink appropriately, and a third of the population have abused alcohol. That's just now, in that third of the population, that doesn't mean a third of the population are alcoholics. They just, at some point in their lives, have abused alcohol by those criteria.
But of course, we also hope when they abuse alcohol in any way, or drugs, that they don't drive. So we want to mention that, because we also run the DUI program.
Correct.
So we want to make sure that people are safe no matter what they do.
Right. And the obviously is to err on the side of caution. So if there's even a question, there are certain calculations you can do for your height and your weight and the amount of alcohol you drink in a certain time. But the idea behind it is if you're even at all concerned about it, then you shouldn't.
Right. And of course, 0.08 comes very quickly to people.
Correct.
Much quicker than they think. So.
Yes. So what they've done is they've taken these 11 criteria, which we'll go over with Joan, and they have determined that if it requires 2 to 3 symptoms of this list to consider to have a mild substance use disorder. So they moved away from addiction and abuse to a substance use disorder. And I'll go over the substances that are included in this list, and then the 11 criteria, and then we'll see whether Joan, you can be Joan's history to tell us whether Joan meet these or not.
I know Joan since high school.
Yeah,
so,
okay. Should be able to answer them. So first of all, in the substance use disorder, these are the different substances that are included in this. And so you can use this criteria that we're going to go over for all of these substances to say whether you have a substance use disorder. So it used to be they categorize into alcohol or opiates. Those were the two big things that they were talking about, but there's actually many more substances on this list. So the DSM-5 established 9 types of substance use disorders. So there's alcohol, there's caffeine, there's cannabis or marijuana, hallucinogens, inhalants, opioids, sedatives, hypnotics, anxiolytics, so those are the benzodiazepines,
Right.
Stimulants, which are cocaine, methamphetamine, and tobacco.
Right.
Okay, so those are the 9 different substances that you can apply the following criteria to. We're just, for Joan, going to do it for alcohol, but you can apply this criteria to any of these substances to determine whether you have a substance use disorder related to your use of that substance.
Okay. And I can't resist asking you, and we'll go back to Joan in a minute. And now, all those substances, certainly, if I don't have my coffee in the morning,
Right.
I'm very cranky, and I know I'm addicted to caffeine. And that's an acceptable addiction in our society.
Right.
Ma'am,
I would correct you to say that you are dependent
Okay.
on caffeine.
okay.
But even in the criteria of addiction, the definition of addiction in the broadest sense is used despite a negative outcome.
Okay.
So now, if you, let's say, your doctor told you you've got a heart arrhythmia, you cannot have any caffeine, and you continue to drink the caffeine, even though you know it's having a negative effect on your body, then it would be an addiction because it's used despite a negative
That's a
outcome.
great distinction. But let's talk a second about marijuana. I don't want to spend too much time on it.
Okay.
But I think a lot of people feel that, marijuana, we use it, it's not addictive,
Right.
it's not, it's not a substance we'd ever abuse. It's sort of in the category of alcohol. What about marijuana? Because we've got a big decision to make in November.
The discussion on marijuana is definitely framed by your point of view, where you are, whether you are a legislator, whether you are in law enforcement, whether you are a user, whether you are a parent, and it all has studies will sway someone's argument one side or the other. It's known that chronic use of, well, it is still debated, I would say, but there's a large body of evidence that says, because some will argue on the other side, that chronic use of marijuana while an adolescent significantly impacts your life. Now, it can impact it by lack of motivation, which they've studied you have, so there's poorer performance in school, poorer performance on the work site. There are studies that shows that there's actually a lowering of your IQ. So things that they can measure about your ability, your executive function, are all decreased with early, heavy use of it.
And certainly one of the latest National Institute of Drug Abuse studies to show that early use of marijuana can lead to addictions later on in life.
Correct. And there's, it's not a direct line, and so it will be argued one way or the other. But I would say that in my own clinical practice, probably 50% of the patients will report alcohol and marijuana use, alcohol and or marijuana use prior to their opiate use.
Okay. So that's why marijuana was on that list. And
Correct.
It belongs on that list.
Correct.
So let's go back to Joan.
Okay.
What are the criteria?
So the criteria are grouped into 4 groups. So I'm going to go over the names of all 4 groups, and then I'll get into each group individually. So you have 11 criteria, and the 4 criteria are broken down into, or the 11 criteria are broken into these 4 categories. It's either impaired control, social impairment, risky use, and pharmacological indications, tolerance and withdrawal. So the first one is...
You'll tell us what that means.
Correct. So in the first one, it's, I'm just reading right off them so I didn't memorize them. Using for a longer period of time than intended or what was your original target. So that is compared control. So I was just using it for a short amount of time, and then all of a sudden it's 2 years, 3 years, 4 years, and I'm still doing it. So it's kind of like I can't stop. Okay, so you're losing control over your use in general. So the second criteria is social, how social impacts your life. So there's a couple different ones here.
I'd say I'd read that for you, but
Yes, I can't.
It's better.
Okay, so just whether impaired control is also wanting to reduce the impact, but you can't. So you know there's a problem, and you're saying, okay, I'm going to stop, or I'm going to decrease it, but you lose the power to be able to do that.
So it really is kind of an obsessive disorder that you can't control and you can't reduce on your own.
Correct.
Okay.
The third criteria is spending excessive amount of times getting, using, or recovering from that. So we're talking, you become obsessed about getting the substance, whether it's going to the liquor store. It's one of your priorities of that day is to get to the liquor store, to carve out time to use it. Some people, let's say Joan's case, Joan may be what we refer to as a closet drinker. She may be not wanting, or someone like Joan may not want to be the person that is out at the bar, but they're drinking by themselves at home. So they're isolating themselves or recovering from it. So it's the hangover in Joan's case, or it's the excessive fatigue that's associated with some of the other substances. The high always is followed by a low. So whether it's stimulants and all of a sudden I sleep for 2 days after one of those types of events. And the fourth is cravings, so that okay, I am having physical and mental obsession with getting that substance.
And it's interesting you say physical and mental obsessions, because there is a physical component to this, isn't there?
Correct.
In addition to sort of wanting it and needing it physically and feeling sick if you don't, but there's also a neurological component to that.
Correct, and it is different when you look at all those 9 substances, it presents very differently. So those 4 are the impaired control. Somehow this substance now has a control over you, how you spend your time, how you think, how you manage your life.
So addicts often say, Brian, that I don't choose the drug chooses me. And when we hear that, we think out of control, not able to control what they do, but they're living day to day, hour to hour to get their drugs and basically continue to use.
Right, and for the patients that I see, especially with opiate use, because you have the availability, and although we're pretty well versed in the fact that the medication's available, you still have to track it down, you still have to find the person, you still have to get it, you have to get the money, and you have to lie to everybody in order to fulfill your morning routine. And so when patients get into recovery, one of the things that I say to them, which they usually agree with me, is that your brain now has this whole area that's open to creativity and thought and productivity and relationships, because you're no longer obsessing about even the mechanics of getting it. Not even using it, just the mechanics of getting it.
Right. A little more time in your day.
Correct. And it's amazing. And, there's a little more money in your pocket as well, which, for somebody who doesn't have it, always seems to have some dollars in their pocket to get what they want. But for many of these patients with substance use disorder, it controls their life so much that they don't have, I have $100 that I've had in 2 days. I never would have had $100 in my pocket.
Right.
Because the minute I had it in my pocket, I would have spent it.
People always hear about the cheap bag of heroin at $5 a bag, and they think, well, no wonder, I can get it for $5. Why not? Why not try it? But eventually it's not $5 a day.
No. And it's not $5 a day, and the $5 bag is now a $20 bag. And, one of the things we go over is tolerance. And what tolerance is, and even Joan probably has experienced it, is the fact it takes more and more of whatever substance it is to get the same effect.
That's right.
And so you develop a tolerance, and all of a sudden, if it's alcohol, it used to be 2 drinks, now it's 4 drinks, now it's I'm opening the second bottle, but I'm not going to finish that bottle. Or I've taken 3 Percocets and now I'm taking 5 Percocets, and I'm trying to do that not to get higher. I'm just trying to get to the same point that I was before.
That's right. That's right.
So again, the first one was impaired control. The second was the social impact of it. So the social impact looks at a couple things. Looks at your performance with structured environments. So everyone's structured environment is different, but it may be school, it may be work, it may be some individual responsibility that you may have, let's say as a caretaker, some type of kind of job-related, employment-related problem. So are you having a problem at school? Are you having a problem at work? Is your performance down? Those are usually somewhat measurable things, because you're interacting with an institution, and then the institution is interacting back with you with your, either you're fired, or you're given warnings, or you're given, numerical information about your productivity, whether it's in a grade or in a work environment. So that's something you can see pretty clearly. So that's one of your social impacts.
That's a true impairment socially, in terms
Correct.
of interacting, in
Yeah.
terms of interacting with your family, doing your job, doing all the pieces.
Right. Yeah. So this one was specifically with that institution. The second one is with interpersonal relationships. Okay. So the next level is not with the institution, but with the person.
Right.
Okay. And the impact seems to be greater the closer the person is to you. So if you think of it almost like a tree that has a center and all the rings around it, and different people in your world sit in different rings, and they may be further or closer from the center. And it's the people at the center or closest to the center who tend to be the most impacted. Mm-hmm. So it's first degree relatives. So it's parent, sibling, child. So all those first degree relatives tend to be the most impacted.
Right.
And then you can go to either second degree relatives or friends. And so they will be impacted. But it's those interpersonal relationships, and the third is interactions that you've given up completely.
Right.
Activities that you've given up.
Right.
So whether it's sports or activity with friends, or things that are lost because of your addiction.
Things that were pleasurable to you that you now substitute with alcohol or a drug and just don't do them. So I think those are great, and those I think are very helpful to people out there in terms of understanding that.
Yeah.
So now you go down that list, and people are now writing these down and saying, my God, my son maybe have a substance use disorder. Or maybe addicted. So what do I do? Where do I go?
Yeah. So, one of the things that you need to do, and just so you know, this is available online, this entire list. And so for people who want to see the rest of the list, that's available online.
Or call Middlesex Recovery.
Or call the Lowell House. Or call probably the first call should be to your physician.
Right.
Because it really is a complex medical problem. So, for the sake of argument, let's say you in your own mind come to the conclusion that there's a problem. Okay, that can be very difficult for different people. And it's difficult to understand that or admit that my child has a problem, and that is the hardest stepping stone for some people. But assuming that you've made it to the point where you're concerned.
So really, denial and stigma, all problems.
Correct. You don't want to admit it to yourself. You don't want to have the conflict, because substance use disorder comes as a plethora of conflicts that exist in somebody's life. And so to bring it up, you have to admit it to yourself and discuss it with someone that may not be comfortable with it themselves. But assuming that you've made it that far, then you need to access care. And the level and speed at which you access care is determined by how much at risk do you see that person. Now, it ranges anywhere from let me call my primary care next week to let me call 911 right now. And that, is on an individual basis. Ultimately, you need to verbalize to whoever the person that you're reaching out to your level of concern. And you can't minimize that. We're not that worried about it, but, because you're a little nervous about it. Say, we are worried about it. It's an issue. We want, a diagnosis, and B, access to care.
And safety first.
Correct.
Okay?
You know,
Don't be embarrassed. Don't be ashamed. Safety first for a loved one, for yourself. Get in touch with your primary care physician. Call Lowell House. And if you need support, and we say this to all the parents, there are groups like Learn to Cope. There's several Learn to Cope groups in Lowell. There are other parent support groups that will help you get through that and the resources that you need to do. So I think this has been extremely helpful, and I wish we had an hour to go over this.
right, I can't believe half hour's up, to tell you the truth, but
It goes quickly, doesn't it?
Yeah.
So we want to say, in closing, again, Middlesex Recovery, tell us a little bit of the range of services.
Yeah.
30 seconds, what do you do?
So Middlesex Recovery is a private practice addiction medicine specialty practice. So we treat both alcohol and opiate abuse. We treat them at multiple levels. We provide counseling, which is by far the most important thing in any treatment protocol. Has to be the counseling, the psychosocial support, identifying mental health issues that are untreated, access to care for mental health, which is very difficult to do. We provide one-on-one counseling. We provide medication-assisted treatment in the forms of Suboxone and Vivitrol. Suboxone is for the treatment of opiate addiction. Vivitrol can be for the treatment of both opiate addiction and alcohol abuse.
Well, thank you. And for all the 5,000 babies that will be born from this point on, I say you're on
They're
your
going to do it
own.
without me.
But thank you very
Yeah.
much for being part of our field, for being part of this area. You add a tremendous amount to this area. So thank you to Dr. Brian O'Connor, and we'll be back in a couple of weeks. And don't forget to tune in. And you can also see the remainder of our episodes are on YouTube. Just subscribe to LTC, or go to the Lowell House website at lowellhouseinc.org. Thank you very much, and have a great week.